So did you guys enjoy melanoma? It's kind of cool, right? I mean, it's kind of different. It's interesting because when we first started talking about melanoma, there was one drug, and I'm sure Dr. Paus talked about that, and it was just dacarbazine, and it stunk. So it's kind of cool to watch the advancement of drug therapy in melanoma, and it's fun to watch because melanoma really is pushing the immunotherapy piece, and whatever we do in melanoma then kind of trickles down to the other cancers. So kind of cool. All right, so we're going to do genomics. Some of this is going to be an overview of what we've already talked about, kind of at a higher level. So we're going to kind of delve a little bit deeper into some of the genomic pieces that we've talked about in Pharmacotherapy 7. And then we're also going to talk about a few other things that we have not touched on at all as far as how genomics plays a role in cancer therapy. Okay. So these are the kind of readings that if you want to look at more information, so the CPIC guidelines, for sure. I'm sure you know where to find them. I'm not the first person that's brought up CPIC guidelines in this class. And then also for some of the guidelines or agents that we'll be talking about, there's these Dutch pharmacogenomics working group guidelines, so you can look at that. And then there's this book in Access Pharmacy, so you can get this for free, that talks about genomics and oncology. It's old, it's an old chapter, so it was published in 2013, and we've come a really long way in just those few years, but the basics are there, and so that would be a good place to kind of just hone your knowledge if you need to. Okay. All right. So just quick background. What is cancer? How does cancer develop? What is it? Okay, uncontrolled cell growth. And usually what causes that uncontrolled cell growth? Mutations, right? Okay. So these uncontrolled cell growth mutations usually are what causes it. So when we start thinking about mutations, we can think about somatic, right, versus germline. Now, are those new terms to you guys? Okay, you've heard them in this class before, right? All right, so our somatic mutations, which are non-inheritable mutations, and then our germline, which are inheritable, right? So we have to kind of pay attention to that in oncology. Okay, I'm not going to use this because it's like going crazy. Okay, all right. So when we look at germline versus somatic mutations in cancer, what do you see up here? What makes up the majority? Somatic mutations, right? So is that good or bad? Depends on perspective, right? You know, if they were all germline mutations, what could we do to everyone? Just genetically profile them, determine what kind of cancers they're going to get, and then do something about it, right? If they're all somatic mutations, do they just pop up whenever? Right? I mean, we don't know when a somatic mutation is going to pop up because it's an acquired mutation. So it makes it a little bit more difficult to kind of maybe screen people and identify people who might be at high risk because we don't know when those mutations are going to occur. And then we've talked about kind of all the way through these kind of familial syndromes. You know, we talked about familial syndromes in colon cancer and in breast cancer. So there's also familial kind of genetic markers that can play a role in the development of cancer. All right, so but the majority of our mutations that we see are somatic. Take that as good or bad, right? So when we think about mutations, we have to think about what type of mutation. So we can think about them as inherited or acquired, somatic or germline, but also we have to think about them as far as like what do they do. So whenever, and especially in oncology, we really think about gain of function, loss of function. Have you guys talked about this before in other disease states, right? So gain of function is usually gene amplification. It might be like a single point mutation also, or it could be chromosomal translocation. So in oncology, give me some examples of what a gain of function mutation might be. Okay, so BCR-ABL, we haven't talked about it, but you guys have looked through your slides, so that's good. What are some things like in the cancers we have talked about? What would be gain of function? Give me a chromosomal translocation other than BCR-ABL that we've talked about. That's BCR-ABL. So the exon 19, those are deletions. So those would be point mutations. So those could be gain of function, right? What's a chromosomal translocation we've talked about? Think about lung cancer. ALK, right? ALK would be a translocation. It's kind of like BCR-ABL. Our exon 19, exon 21, those would be a point mutation or deletions. Those can be activating our gain of function mutations. Okay. How about loss of function mutations? So this is when something gets turned off, right? So give me an example of maybe a loss of function mutation. P53, classic example, right? So usually we think of gain of function mutations as oncogenes that have been turned on, and loss of function mutations as tumor suppressor genes that have been turned off, right? So P53 is a great example. In colon cancer, do you remember what gene has to be turned off to like start the whole process of colon cancer? There was a gene that Dr. Davis talked about. APC. All right, so the APC gene, like once that goes, then we're on a full-blown path to developing malignant colon cancer. So these would be examples of loss of function, gain of function mutations. Okay. All right. So when we think about this, right, you and I, we're all sitting here. We all walked in today breathing the same air, right? You guys probably ate a better breakfast than I did. But, so we're all exposed to the kind of the same environmental type things, I guess, for the most part. So why is it that when we're all exposed to these same things, not everybody gets cancer, right? You hear these stories of people who smoke for 60 years every day, and they never get lung cancer, right? Right. And then here, my mom never smoked in her life, developed stage 4 lung cancer, and died. So how does that happen, right? So really, a lot of this may have to do with polymorphisms, right? Polymorphisms either in drug metabolizing enzymes or in DNA repair enzymes or something that's led to a mutation to develop, right? So it's this kind of polymorphic picture that presents that puts people at risk over their lifetime. So this is just an example here of BRCA. Where does BRCA play a role in? What cancers? Okay, breast, ovarian. Okay, you can see it in prostate as well. You can actually see some BRCA in pancreatic. So there's a couple of different places where we see BRCA mutations play a role. Okay, so is BRCA a gain of function or a loss of function? Huh? It's a loss of function, right? Right, because it's a tumor suppressor. All right, so here this is looking at BRCA carriers versus general population, right? So we can see BRCA carriers are kind of in this yellow. Is that kind of yellow to you guys? What color is that? Okay, and then blue. All right, so you can see their risk of developing breast cancer by age, right? So by age 50, if you have a BRCA mutation, you have a 50% chance of developing breast cancer. By 70, it goes up almost double, goes almost doubles, right? Goes up. And then you see here for ovarian cancer, right? And that's compared to that general population. So you can see how this mutation will put people at risk for cancers, right? So these DNA, and BRCA is what does it do? Right, it's a DNA repair enzyme, right? So this is how these polymorphisms can occur, and then that occurrence will lead to the development of cancer. Okay, I really feel like I should be like dancing or something while I'm up here with my microphone. So, all right. So if we think about hereditary syndromes, it's really kind of weird, but anyway. So hereditary syndromes, a lot of these are involved with our kind of more gene repair or DNA repair type enzymes. So these are some just examples of hereditary syndromes and the cancers that they are involved with, right? So you hear about this hereditary breast cancer, which is involved with BRCA, right? So like I said, it can also be prostate. It also can be pancreatic. Then we have Li-Fraumeni. You guys have probably heard that several times because loss of P53 can cause numerous things, not just cancer, right? And then we talked about Lynch syndrome, right? Lynch syndrome is associated primarily with what cancer? colon cancer, okay. And then there's this APC, or the familial adenomatous polyposis, right, which is a familial syndrome that occurs with colon cancer. And what's unique about that? Yeah, early onset, right? So by the time people are teenagers, they have thousands of polyps in their colon, right? All right, then we have this kind of multiple endocrine neoplasia that leads to thyroid cancer, and then this von Hippel-Lindau, which is a really angiogenic type gene that will lead to kidney cancer. Okay, so these are just some examples of how these DNA repair enzymes or these genetic polymorphisms will lead to cancers. Okay, so just like some of these things can lead to the development of cancer, some of these genetic susceptibilities can also alter a patient's response to treatment, right? So if we think about, if we give 10 people, right, 10 patients carboplatin pemetrexed for adenocarcinoma of the lung, okay, will they all respond the same way? No, right? So everybody, I could have 10 stage 4 lung cancers, adenocarcinoma. We give them carbopem. Is carbopem frontline? Is that recommended therapy? Yeah, it's recommended therapy. So why don't they all respond? Right? So this is what, this is where we run into inter and intra heterozygosity. What do I mean by heterozygosity? What does that mean? Differences in? No, not necessarily response, but gene what? Yeah, genotypes, right? So not everybody's going to have the same genotype, right? They may all have adenocarcinoma of the lung, but they're not all the same genotype, right? They're not all from the same, same genetic thread, right? So with that, we have intra and inter heterozygosity, right? So not everybody's genes are all the same. We could even have, two brothers that have this, and they won't exactly have the same genes, right? So the question is, if we have two twins, right, or quadruplets or septuplets or whatever you want to do, so they're identical, right, could we expect that they would respond the same? Maybe, but we also have these host-specific factors, right? So host-specific factors can be environmental, right? So were they both exposed to the same thing all their life, right? So maybe, maybe the chances would be more likely that they might respond the same, right? But we have to take into account not only just the genetic factors, but that kind of the environmental factors that may lead to not only germline mutations, but also somatic mutations, right? Okay. So this is the bane of our existence in oncology, why everyone does not respond, okay? So with the advent of looking at genomics and genomics becoming playing a bigger part in cancer care and the understanding of genomics, the American Society of Clinical Oncology, or ASCO, is kind of like the ASHP of oncology. Right, it's a big, huge organization. They put together this policy statement related to genetic and genomic testing for cancer susceptibility. And so in this policy, they came up with a couple of kind of guideline recommendations, okay? So the first thing is, what happens if you go out and looking for somatic mutations? Say somebody is diagnosed with lung cancer, okay? What mutations right off the bat are we going to look for? ALK. What is it? ROS. Okay, ROS. EGFR. There's one more that we're going to look at, mutation-wise. BRAF, right? So we're going to look at BRAF. Okay. PDL status, is that a mutation? No, that's not a mutation. Okay. So say we go out, have a lung cancer patient, we go out and do genetic testing for looking for somatic mutations, and a germline mutation pops up. So what do you do with that? You're not looking for that germline mutation. That germline mutation may have nothing to do with your cancer, So what should you do with that information? Right? So that's this question here. Germline implications of somatic mutation profiling. So they give some kind of guidance to say that if you find a germline mutation that's, needs to be acted on, right, you got to let the person know, right? You can't just keep all that information to yourself. Okay. All right. They talk about the fact that you really should be doing multi-gene panel for cancer susceptibility, so maybe not just one type of methodology to identify the mutations, maybe multiple different ways to test for these kind of mutations. Okay. They talk about quality assurance, so making sure you send it to the right place. So do the test, right? Because you don't want to just send it to somewhere and get a bunch of false negatives, right? Because if you're a lung cancer patient and you have an EGFR mutation, but they don't do the test correctly, and they come back with you don't have an EGFR mutation, and you get chemo, what do we know? You actually don't do as well, right? People who have EGFR mutations who get chemo actually have a worse outcome than those who don't have the EGFR mutation, right? All right, so making sure we have good quality assurance in that genetic testing. Educating oncology professionals, right? So making sure that all the oncology professionals, providers who are taking care of these patients, understand what these results mean and how it implicates what treatment we're going to give, what toxicities we might expect, what we might think about prognostically, right? So making sure that we all understand how these genetic tests can be used to treat and benefit our patients, right? And then lastly, making sure that patients have access to these services, right? You don't want to be, I don't think this would ever happen, but right, you don't want to be in the middle of nowhere, America, get diagnosed with lung cancer, and the person not even offer you, genetic testing to identify those mutations, right? So, all right. So this is kind of what they came up with as far as recommendations. And this is kind of old. This was published in 2015. I'm really surprised they have not updated it yet, just with the strides that we've made and how we are identifying and testing for genetic mutations and how quickly they're being incorporated into treatment. And as far as identifying standards of care and frontline treatments. So I'm guessing that they'll probably update this sooner than later, but it's interesting that they put that out there so that there's some structure around how these mutations are utilized in the treatment of patients with cancer. Okay. So tumor profiling gives us important information, right, about specific genes that may be involved in our cancers. Okay. So it helps us identify normal kind of genes versus mutated genes, right? So we can look at the difference in the genes. And the differences can be used for either diagnosis, right, or prognosis, or to help us determine if a patient's going to respond, right, to therapy. So we've kind of talked about these before in Pharmacotherapy 7. So different ways that we can profile tumor. We've talked about immunohistochemistry before, right? So this would just be staining the cells to see what kind of expression, protein expression the cell may have, right? So you can stain them for HER2 or for BRAF or things like that. We also have talked about FISH. Where do we use FISH primarily in the cancers that we've learned about? Okay, breast cancer, right? So breast cancer, especially looking at HER2, all right? This is where we just kind of tag those mutations or tag those genes with this fluorescence, right? And then we can kind of see how it shows up. So this is a picture of BCR-ABL, right? So this shows you the translocation. This is BCR, I think. This is ABL. So they should be two distinct, different colors. But when you have this gene fusion, right, you get the blending. So you can see where the translocations occurred. So you have the ABL piece and the BCR piece mixed together. Okay, so you can see those in these cells here. So we can use FISH as providing some kind of genetic or tumor profiling for us. But realistically, in the last probably 10 years, we've gotten so much better at really identifying these. We have all of these different kind of methodologies that we use beyond just FISH and IHC. Okay, So we really started out with like PCR, right? So a quantitative polymerase chain reaction. And then we went into kind of this pyro-seq testing. But now really everyone uses next gen or this next generation sequencing. And that's kind of probably the most commonly used methodology that we see in oncology. One, because it's super fast. We can get results within just within a couple weeks. And it's become super cheap in doing that. All right. And it's able to really broadly look at the whole DNA. Instead of just looking at specific, like with PCR, we just look at specific fragments of the DNA. Okay. So there's a bunch of different tests. You don't need to know these by heart, but just know that there's a bunch of different ways that you can do it. And NextGen actually takes into account, it uses kind of multiple different methodologies to develop its outcome. So these are some examples that we use just to kind of how it looks. So this is PCR, right? So we're like copying the DNA and looking at it. Over here, this is DNA microarray. All right, have you guys ever seen this? Has anybody showed you DNA microarray before? So this is diffuse large B-cell lymphoma, which we haven't talked about, but these are all of the genes that are involved in it. All right, so these are all up here. These are all the tumor suppressor genes, and these are all the tumor oncogenes kind of involved with diffuse large B-cell lymphoma. So this just kind of maps it out by the different types of diffuse large B-cell lymphoma and kind of shows you what's the normal genomic profile is, right? So if they're green, that means they're doing all what they're supposed to be doing. If they're red down here, it means they're doing what they're supposed to be doing. But if you start to see some greens or reds mixed in where they're not, that means there's mutations in those specific genes, right? And then you start to see a disease genomic pattern, right? So you can see that if you have classic Burkitt's or atypical Burkitt's, your genetic profile looks very different than people who have kind of our typical normal diffuse large B cell, right? And then vice versa. So then we can use this to identify, so this person here has this gene, and we can figure out if there's any kind of targetable or actionable treatments for that. Okay. So these are a couple of different methodologies. Oh, and then this next one is the next gen. Right, so next-gen is taking extracted DNA, fragmenting it out, finding these kind of ligated adapters, copying them through the whole genome sequencing, and then adding fluorescent tags to them, and then kind of doing these passes across the DNA to build the DNA code. And then they take that DNA code and they reference it with what we know a normal genome should look like, who does not have mutations. And then we are able to identify where potential mutations are occurring, and then identify how that mutation may be either causing the development of cancer or causing lack of response to treatment. Okay, so a bunch of different ways to do it. You don't really have to know a lot about them other than I just wanted to show you the general process. Basically, all we get in clinic is we send these samples off, and then we get a report that says KRAS mutant, KRAS wild type, so that's what we get. So that's what you guys will see. Okay. All right. So applications in oncology, right? So we've gone out, we've looked for all these mutations, we've identified them. What are we going to do with them? So not only do we see dependent kind of responses or differences in response, but we also see differences in toxicity with these. So what are the factors that can lead up to that? All right, age can always be a factor. You have fewer somatic mutations when you're older or more? More, right? As we age, we just kind of gain these somatic mutations. So that can lead to these differences. Sex, right? Male versus female, right? When we look at cancers, who's usually more likely to get a cancer? Males, right? Males are usually more likely to get cancer. So there's probably some dependency there. We also could have to think about drug-drug interactions, right? So that has nothing to do with genomics, maybe. but maybe not, but drug-drug interactions. And then our genomics come into play. Right, and then we have to think about our mutation types, right? So is it gain of function, is it loss of function? What type of mutation is it, and how is it going to affect response or toxicity? Okay, so when we have these mutations, we have to think about how we're going to use them. And we've talked about this in class in PT7 before, right? We can use it as a diagnostic value. Okay, so I just use the example here, BRAF, and then the way BRAF can be used in different ways, right? So BRAF is diagnostic for patients who develop a certain kind of thyroid cancer, right? If they have we have thyroid tissue and it has a BRAF mutation, they will have medullary thyroid cancer, okay? So that's diagnostic. Prognostic in colon cancer, what do we know about BRAF for colon, prognostically? It's a bad outcome, right? Okay. Predictively, you just got a good refresher in melanoma. BRAF is, if we have a BRAF mutation, what does that mean? Okay, you respond to our BRAF inhibitors, right? Right. So here, BRAF can be used 3 different ways: diagnostically, prognostically, and also predictively in different cancers. Okay. Then you can also have kind of a dosing value. All right. So this is not a tumor that we'll talk about really ever. It's not a very common tumor, but it's called gastrointestinal stromal tumors. And these gastrointestinal stromal tumors are GIST. We call them GIST because it's so much easier to say. GIST tumors will likely have KIT mutations. Okay, so KIT is in that kind of MAP kinase, or another kind of pathway like the MAP kinase pathway. If you have a KIT mutation, you need to look at specific mutations within KIT to determine what dose of drug we're going to give you. Okay, so KIT mutations and GIST respond to imatinib, which is a BCR-ABL inhibitor, but it also has KIT activity. All right, if you have a KIT mutation in exon 9, if we give you the normal imatinib dose for GIST, you will not respond. We have to essentially double the dose for you to get a response. So most patients with GIST will start with 400 milligrams per day of imatinib, but if you have this exon 9 mutation within KIT, then you have to have 800 a day. Okay, if you get 800 a day, you do just as well as those people who get 400 a day who don't have the mutation. Okay, so sometimes these mutations can have play a part in dosing and how we dose our patients. Okay, all right, so just some different ways that we apply these mutations in oncology. Does that make sense? Okay, is this all pretty much a basic review? Okay, all right. So what do we do with this information? All right, so you've seen this before, not anything really new, right? So for non-small cell lung cancer, we look at our ALK and our EGFRs. What kind is it? Is it a rearrangement or a mutation? What does it tell us? These are predictive or prognostic? ALK and EGFR. They're predictive, right? Okay. So colon cancer, KRAS and BRAF, right? So KRAS is predictive of treatment, right? And BRAF is predictive of prognosis. Here's our BRAF and our thyroid cancers right here. So if you have a BRAF mutation in this type of cancer, it's a high probability of malignancy. Okay. It also can be linked to poor prognosis. Melanoma, it's predictive. And then, like I said, in GIST, it can be predictive to response or resistance to your TKI. And so that can tell us how to modulate the dose. Okay. All right. So why is this information essential? Because these little boxes in green, these have become standard of care. Right. So this genomic information has now changed the way that we practice and treat our patients, and that those changes have resulted in what? What have those changes resulted in these patients? Better outcomes, right? People are living years, right, with lung cancer if we've identified these mutations versus months, right? All right. Same thing with melanoma, right? Now we've identified these mutations. Before with dacarbazine, we had like a 20% response rate. Now we have patients living out, 5, 10 years. Okay. So that's why this information is essential. Yes, right? Because what does it tell us in colon cancer? What do we know about KRAS? So, right, so if you're a mutant, we don't give you an EGFR inhibitor, right? That's going to impact how we treat you. So, yes, it is around. I didn't probably extend my box all the way, but okay. All right, so let's talk about germline mutations. All right, we've not really talked about germline mutations. We spent most of our time talking about somatic mutations in PT7, but germline mutations are important. All right, so the first germline mutation we'll talk about, we'll put this case up here to kind of have you think about it as we talk through these mutations. So we have a 5-year-old male with acute lymphoblastic leukemia. So we know ALL is the most common cancer in kids. He's receiving 6-mercaptopurine, what kind of drug is 6-mercaptopurine? Do you know what class it is? It's a purine analog, so it would be a anti-metabolite. Okay, good. All right, so he's getting 1.5 milligrams per kilogram per day as part of his maintenance treatment. All right, so if you know anything about ALL, they get like initial kind of treatment, and then they get consolidation treatment, and then they have this like 2-year maintenance treatment, and that cures 98% of, I think 96% of all ALLs. Okay, if you gave that much chemo to an adult, you would kill him. But little kids can like suck chemo up like nobody's business. So his weight is 20.5 kilograms. So what would be his total dose be? Some quick math in your head. Do I? 30, 31, 32-ish. All right, 32 milligrams per day. All right. What toxicities do we typically expect from antimetabolites? What? Mucositis, maybe alopecia, myelosuppression, what other GI? Diarrhea, things like that. Nausea, you can see nausea with mercaptopurine. Okay. What toxicity would you expect if he was deficient in TMPT or thiopurine methyltransferase? Okay. All right, let's figure that out. That's a cliffhanger, right? Dun, dun, dun. Should we wait for like 30 minutes and then I'll come back and like repeat the same 5 slides before, like a reality TV show? Okay. All right. I'm like, you just are telling me what I watched just for the last 25 minutes. But anyway. All right. So TPMT. So this thiopurine methyltransferase. So it's the enzyme responsible for metabolizing azathioprine. Where have you guys seen azathioprine before? Right. So our kind of inflammatory bowel type diseases, right? It also metabolizes 6-mercaptopurine and thioguanine. Okay. So from my standpoint, azathioprine is kind of a cool drug. We don't really use it in oncology all that much. We really use 6-mercaptopurine and thioguanines in the treatment of leukemias, and primarily for our kids. We use it a little bit in adults, but mostly for our kiddos. Okay, so this just kind of goes through where TPMT plays a part. So azathioprine actually is a prodrug that gets metabolized into 6-mercaptopurine, right? Then 6-mercaptopurine gets incorporated into the cell and then gets converted basically into these thioguanine nucleotides. And just like any other antimetabolite, these thioguanine nucleotides get converted from monophosphate to triphosphates and then get incorporated into, right, DNA and RNA, right? So they work like most of our antimetabolites. All right, so TPMT comes into play here, right here, where it metabolizes these kind of active thioguanine, these active thioguanine nucleotides into these inactive or nucleotides. Okay, so right here. It also will inactivate this this is the monophosphate form, so that it will inactivate the monophosphate form into this kind of inactive form. Okay, all right. So along the way in this process, we've got TPMT that's kind of pulling active drug or active nucleotides out into inactive nucleotides. Okay. Thioguanine just goes straight into these thioguanine nucleotides. Okay. All right. So when we look at TPMT, we know that it's an autosomal recessive trait. Okay. And most loss of function enzymes are usually recessive. So, this is a loss of function, right? Our enzymes no longer able to metabolize things into the inactive form. Okay. If we can't metabolize active drug into the inactive form, what's going to happen? Lots of toxicity, right? Okay. So within TPMT, we know there's 3 alleles that account for about 90% of all enzyme deficiencies. All right, star 2A, star 3A, or star 2, star 3A, and star 3C. Okay. And this deficiency will result in severe myelosuppression in these patients. Okay. Which is not great. Maybe we want myelosuppression, but we don't want severe myelosuppression. Because if they have severe myelosuppression, what do we worry about? Anemia, immune compromise, infections, febrile neutropenia. What do all of those tend to lead to if we don't take care of them quickly? Sepsis and death. Okay. Usually not on our treatment plan. Okay. All right. So when we look at the TPMT, we look at kind of the percentage of people who have normal, fully functional enzymes doing what they're supposed to do. We see it's really the majority of our, of us. All right. We look at people who are heterozygous or who have intermediate activity. Right. So these are people who carry like one functional allele and one non-functional allele. Right. So it's about maybe up to 15% of the population. And then those who have homozygous variant or low, right? It's a very, very small part of the frequency. So a very small part of the population. But these would be people who carry 2 functional alleles, okay? All right. We know that there are some ethnic differences in these alleles, right? So Caucasians are typically more likely to have star 2 and star 3A, where Asians are more likely to have star 3. Right? South Americans are more likely to have star 2, so kind of Hispanic origins. So there are definitely some ethnic frequencies in these alleles. So it's kind of important to understand that when you may be thinking about treating a patient. Yes. Yep. So it'll be important that you understand what the alleles and the genotypes are, because it's going to depend on how we treat patients, right? Okay, so those would be important. Okay, so just remember with this, there's some ethnic differences that we may have to pay attention to when we're kind of treating patients. Okay. So if you look at the CPIC guidelines, they get a little complicated, so I didn't put the whole thing in here. But if you look at the CPIC guidelines for TPMT, and treating patients with either azathioprine, 6-captoprine, or thiopurine, right? If you're homozygous wild type, you have 2 fully functional alleles. Do we make any adjustments? No, right? That's pretty logical, right? If you're intermediate, right? So you have 1 functional and 1 non-functional. Okay, we're going to want to start at 30 to 70% of your dose. Okay, so, and then we're going to basically give these patients the drug, and then based on their toxicity, we may titrate up or we may titrate down. Okay, and I'll just tell you, for TPMT and the PD population, they always test for this. They test it in every ALL patient just off the bat, just to determine what's going on. Okay, all right, so 30 to 70%. Of the full dose. Okay. All right. I'll tell you for thioguanine, typically we do 30 to 50% of the dose instead of going all the way up to 70. But if you just did anywhere between 30 and 70, it would be appropriate. Okay. Your homozygous variant, so you have two non-functional alleles. Typically what we do is we have a 90% reduction. So how much of the dose are they actually getting? 10% of the dose, all right? And we also reduce their frequency to 3 times per week versus daily. Okay, so our little guy was getting 32 milligrams every day, right? So this, we would significantly reduce the dose and give it basically every other day or 3 times a week in these patients. Okay. So knowing that mutation is going to significantly impact how you treat your patient. Somebody Google 6-mercaptopurine and find its package insert and see if the FDA remarks about this. So you see what the FDA says. See if they have any dosing guidelines for it. Yep. Okay. While you guys are looking, I'm going to answer a question. Yes. Yeah, so it's mostly hepatic metabolism, but like I said, we get this metabolism of the inactive metabolites, right? But we get the breakdown to the inactive metabolites through that TPMT intracellularly. Mm-hmm. Yeah. All right. Did anybody find 6-mercaptopurine? What's in the package insert? Is there anything about dosing changes based on TPMT status? It says test for it, but it doesn't give you any guidance. Okay, so this is the reason why I just want to bring this up, right? So if you're working in a pharmacy, right, on a weekend, say it's a weekend, you're working over at Children's, you're filling in for somebody sends you a script for a 6-mercaptopurine to fill to send home for this patient. You're like, I've never seen this drug before. What do I need to know about it? You pull out the package insert, right? It's always a great reference. Is it really going to tell you what you need to know about, is that dose appropriate for that patient? No. Okay. All right. So it's important to be thinking about these things because sometimes you may have to go to multiple places to learn about how you need to dose or dose adjust treatment for a patient. Okay. For the low people, So you have to kind of fiddle around, and if you just go to the package insert, you may not be able to find it depending on which 6-mercaptopurine generic drug you pull up. Yeah. So it doesn't give you really clear direction. I mean, these aren't really clear either, but right, 30 to 70%, that's a pretty broad range to give a dose reduction, right? But still, if you just pulled it up, you may or may not have a good sense of what goes on. So just understanding how these genomic kind of guidelines can play into treatment of a patient. Okay. So for a long time, all we had was TPMT, but within, I think it was late 2016, early 2017, this other enzyme popped up in the whole TPMT kind of thiopurine metabolism. So this new enzyme is called NUD-T15, or NUD-T15. And so there's polymorphisms that can occur in this NUD-T15 that will also affect thiopurine metabolism. And the reason why this was found is because we were still seeing severe myelosuppression in certain groups of patients, even though they didn't have a TPMT deficiency. All right, so this enzyme came into play. So NUD-T15, basically what it does is it dehydroxylates your triphosphate back to a monophosphate. All right, so it's kind of balancing out that conversion. So how much of it's going into triphosphate back to monophosphate? So if you're taking it from here to here, what are you doing to its activity? you're actually decreasing it, right? But if you have a mutation in this enzyme where it doesn't work, what happens here now? You're getting a lot of accumulation of that triphosphate, which is going to get incorporated, which is going to cause a lot of myelosuppression. Okay. So this NUD-T15 has now been discovered. All right, so people who have low functional alleles are unable to tolerate thiopurines, so they have a very similar response to those people who have deficiencies in TPMT. They get severe myelosuppression, right? Where we didn't see a lot, so in TPMT, it's very rarely occurs, the deficiencies very rarely occur in Asians. This occurs much more commonly in Asians than other patient populations. So this is where we're seeing children in Japan primarily who didn't have TPT deficiencies still having severe myelosuppression to these thioguanines. And so this is how this was primarily discovered. Okay. So dose is tolerated, right? So it looks very much like a severe TPMT. You basically get 10% of your dose, all right, in these patients. And CPIC has not developed a guideline around NUD-T15 yet, but it's on their radar. It's on their website. If you look at it, it says they're going to be putting together a guideline with dosing recommendations for it. Okay. So a couple of different germline mutations that affect the thioguanines. Okay. I'm going to start this, and then we'll go through this slide, and then we'll take a break. Okay. So the next germline mutation that will play a part for you guys to really think about is dihydropyridine dehydrogenase. Okay. So this is a major, the major enzyme responsible for converting 5-FU to its inactive form. Okay. It is responsible for inactivation of about 85% of 5-FU. All right, so the majority of 5-FU is going to get inactivated this way. It's also an autosomal recessive trait. Okay, and there's polymorphisms that again also occur in this gene. The most common is the DPYD star 2A, and their CPIC's really moving away from using star 2A or star 2A, star 3A, star that, using these kind of haplogenes for DPD, and we'll talk about that in a second, just because there's so many different variants that can occur. When you look at the list, it's mind-boggling. I pulled up the list on the CPIC guidelines just to see, and they've probably added 60 new variants since last year when I looked that up. Okay, all right, so just remember, DPD plays a big role in activating 5-FU. It also inactivates capecitabine because capecitabine is like 5-FU. Okay, let's take a break. And we'll come back in 10 minutes and we'll finish our lecture. So let's get back to DPYD. All right, so like I said, realistically for DPYD, they're trying to get away from the haplotype kind of naming designation. So depending upon where you look in a guideline, you may see the haplotype, but you also might see the RSID number, or they may actually give you this nucleotide change information. So like I said, there's probably 100 different variants, so that's why they're moving away from the haplotype, because some of these variants don't match a haplotype. Okay, so what I did here is I try to take a chart from the CPIC guidelines and kind of adapt it together so you can kind of match the haplotype with the ID number with the nucleotide change information. All right. Do you have to remember all of these? I'm going to ask you about the haplotypes. Okay, but I want you to know, the only reason I'm doing that is because it's going to make it easy for you. But I want you to know in the real world, you may not find haplotype. You may find the RSID number. Okay, but for testing purposes, I'll ask you haplotypes because it's just easier than you having to memorize strings of numbers. Okay, all right. So these are probably the most well-studied mutations that occur in DPYD. All right, and so I put them up here. And what the CPIC guidelines have done is they've defined what the allelic status is. Is it functional, non-functional? Is it decreased? All right, and then they've given them activity scores based on the function. All right, have you guys seen this with other guidelines that you guys have used through CPIC? Have they done activity scores? Okay, they're doing this more in oncology as we're learning and evolving more with our understanding. All right, so you can see our two normal, right, haplotypes, so normal function, our star 5 and our star 9A, they're going to get an activity score of 1. Our decreased haplotypes, so hap B, and then this one doesn't have a haplotype because, like I said, some of the variants don't match haplotypes. These are our decreased. They're going to get an activity score of 0.5. And then we have our no function, all right, alleles here, which are star 2A and star 13. All right, they're going to get a 0 function. Okay. So those are the ones that have the most data. Now there's still star 3, A, star 3C. I just didn't include them here because they don't have as much data on them, but they still do exist. Okay. So just like we looked at with TPMT, this is the frequency at which these mutations occur and who's a normal metabolizer, who's an intermediate metabolizer, poor metabolizer. So you can see people who metabolize 5-FU normally would be, the majority of patients, with up to 5% being intermediate metabolizers, and then a very small percent of the patient population being poor metabolizers. Okay, so again, they're going to get these activity scores. So if you had 2 fully functional alleles, right, they're 1 and 1, gives you 2. If you have 1 normal and 1 decreased, then you could be like 1 or 1.5, right, or 1 and a non-functioning 1. And then if you have 2 non-functional alleles, then you can be anywhere from 0 to 0.5. Does that make sense from an activity score standpoint? Okay, good. All right. Toxicity-wise, what would we would expect if you had a person who was a poor metabolizer? What are going to be our side effects from 5-FU or capecitabine? Diarrhea, mucositis, hand-foot syndrome. Will we get myelosuppression? Okay. Myelosuppression is not typically a side effect that we see in great extremes in normal metabolizers, but if you're a poor metabolizer, those people can have severe myelosuppression. Okay. All right. So basically everything times 10. Right. I was telling some people earlier, I've been here about 20 years, and I've seen 4 people with 5-FU have severe toxicity. And they had, their neutrophil count was like 100. Their mouth and their GI tract was just a mess for weeks because they had terrible mucositis, terrible diarrhea, because they couldn't metabolize out their 5-FU. So we had to get some antidotes to help kind of minimize the impact on them. Okay, so that kind of explains that 0.2%, right? We probably give 50 people a day 5-FU, and I've seen it, like I said, 4 times over the last 20 years. Okay, all right. So overt toxicity is what we would see with these patients. All right. So what do we do here? What are the guidelines? What do the guidelines recommend? Okay. So if you're a normal metabolizer, do we have any dose modifications? No. All right. If you're an intermediate metabolizer, right, they're going to, again, suggest anywhere from a 30 to 70% reduction in these patients. And they're going to base this over here based on the activity score, right? So the activity score is based on, do you have a functional and non-functional kind of allele, all right? So if you have an activity score of 1, they say to reduce the dose by 50%. If you have an activity score of 1.5, to reduce the dose by 25 to 50%, all right? So 1 would be kind of closer to a poor metabolizer. 1.5 would be closer to a normal metabolizer, okay? All right. Then if you're a poor metabolizer, again, they're going to base it on your activity score. So if you're 0, they say to avoid 5-FU altogether. If you're 0.5, they say to avoid it. But if you absolutely have to use it clinically for that type of cancer, they strongly recommend a reduced dose. No clear guidelines what that reduced dose would be, but it's a strong recommendation that you start at a very low dose. So the question is, can you extrapolate this to capecitabine? And yes, you can, right? Because capecitabine is just a prodrug of 5-FU. Okay. All right. Who wants to Google a 5-FU and see if there's any kind of labeling information in the package insert about this? And while you're at it, just go ahead and Google irinotecan too, because we're going to do the same thing for irinotecan when we get there. It's always hard to find package inserts for 5-FU because it's generic, but look up capecitabine if you can't find 5-FU, because capecitabine will be easier. Anybody find anything? All right, so it mentions DPYD deficiency, right? And what does it say? Give you any kind of clear guidance? It says you should test for it, right? But again, it's like TPMT. It says you should test for it. There's a little bit more structure around TPMT because we understand that enzyme more and we use it. But for this, there's no real guidance in any of those package inserts to tell you what to do. Okay. All right. I'll tell you, in the real world, TPMT, everybody gets tested if you're a kid. Adults, it's a little less likely. DPYD, we don't routinely test our patients here at our cancer center at all for this. Why do you think our physicians don't routinely test people? Testing's not terribly expensive, but what did you say? Okay, so clinical utility. What's the occurrence rate of these poor metabolizers? 0.2% of the population. How many people have I said I've seen in 20 years? 4. Right? So is it worth testing those 50 people a day that we give 5-FU when we may have just a small sliver of the patient population? Right? So there's some historical perspective that our physicians have of like, well, if I give them 5-FU and they have side effects, then I'll just reduce the dose. So why do I need to test for it? Right? So the clinical argument is, for those 4 people who got terrible toxicity and who were in the hospital for at least 2 weeks, right, it might be worth it. So you're seeing now more pharmacogenomics programs incorporated into hospitals, doing kind of broad gene panel testing up front, identifying any of these things, and then incorporating any kind of clinical implications in as something might come up, right? So right now we don't routinely test for it, but I would imagine in the next couple of years with our personalized medicine initiatives that we have here at the on campus and at the hospital that's going to change. Okay. So, but most places you go probably won't test for it. All right. So UGT 101. So this is the enzyme responsible for the glucuronidation of irinotecan into SN38. Okay. All right. So SN38 here, I'm sorry, it's not responsible for the glucuronidation. It's the conversion of this to this. It's the conversion of SN38 to its inactive metabolite. Okay. So irinotecan is a prodrug, gets converted into SN38 through this carboxyl esterase, forms this active metabolite SN38. SN38 is 1,000 times more potent than irinotecan. So it's super, super potent. All right. You need UGT1A1 to make that inactive. Okay. All right. The most common polymorphisms we see with this are usually UGT1A1 star 28. That's probably the most common variant that we'll see, or our mutation that we'll see with this. Okay, so just like our other cancers, we have our homozygous wild type, our heterozygous, and our homozygous deficient, right? There again, there are some ethnic differences here. So Asians are more likely to be wild type, then Caucasians, and then Africans. Okay. If we look at the heterozygous or the intermediate activity, typically Caucasians are more likely to be intermediate, followed by Asians, followed by Africans. And then the Africans are most likely to be homozygous variant low or deficient. Okay. So there's some ethnic differences here, again, that we may want to think about if we're starting to see overt toxicity in people. It may be related to some kind of drug metabolizing enzyme deficiency. Okay. What are the main toxicities that we see with irinotecan? Diarrhea, right? I ran to the can. All right, so diarrhea. What else can we see with irinotecan? Myelosuppression. It's way more myelosuppressive than 5-FU. Okay, a lot more nausea with this. We can see alopecia. We can see a lot of other kind of side effects as a result. All right, FDA labeling. Did somebody pull up irinotecan? Go ahead and pull up irinotecan. What do you think it's going to say? The same thing as all the others, right? No clear guidance on what to do. So we have a couple of different guidelines here. So this Royal Dutch Association Working Group guideline looked at patients and determined if they're homozygous wild type or heterozygous, there really should be no changes to the dosing of irinotecan. But if you're homozygous variant, depending on the dose that we use, we may make dose reductions. And I'll tell you right now, these doses right here, this 250 milligrams per meter squared or greater than that, we rarely use those doses, only if we're using single agent irinotecan. Normally that we don't give them because of the toxicity that we see. If it's less than 250 milligrams per meter squared, we won't make any dose adjustments. If it's more than that, we would reduce the dose by 30% and then titrate based on toxicity if we need to go up or down. Okay. There's also a group in France who kind of explored this a little bit more in detail, utilizing dosing that we would use with FOLFIRI or FOLFOX. Okay, so and basically they kind of showed a similar thing. So these doses that we would see in FOLFOXIRI or FOLFIRINOX or FOLFIRI, where we would use less than 180 milligrams, they wouldn't really recommend testing because it's a lower dose. So they would just give the dose. Okay. If we're getting into higher doses, so kind of 180 up to 230 milligrams per meter squared, they would recommend testing. And then based on if you're wild type, you would get full dose. If you're kind of an intermediate metabolizer or low metabolizer, they would say to think about looking at a dose reduction for those patients. And then when you get to really high dose here, the same kind of thing. If you're a wild type, no dose reduction. If you're fully mutated, they would not recommend dosing. And if you're a heterozygote or intermediate, they would think about a dose reduction. Okay. All right. Is that pretty clear? Pretty straightforward? Okay. All right. So we won't go through this case just for the sake of time, but this is thinking about, well, maybe we will. Okay, it won't take us long. So stage 4 colon cancer, received FOLFOX and Bev, had disease progression, not a candidate for cetuximab. So what would your options be? Can't get an EGFR. I mean, it's right here for you, but can't get FOLFOX, right? So you're now onto your irinotecan containing regimens. Okay, so we're gonna give single agent irinotecan for this guy every 3 weeks. I put a height and weight there if you want to calculate his PSA. All right, so should we do genetic testing on him? What's the dose of irinotecan? I didn't put it in there. So single agent dosing is usually 350 milligrams per meter squared. So should we do testing on him? If you follow the French guidelines. Yeah, we should. Okay. All right. So based on the results of the test, what are we going to do? What if he's totally normal, wild type, full-blown metabolizer? No adjustments. What if he's intermediate, a heterozygote? What should we do? Okay. So monitor and maybe think about decreasing the initial dose by how much? About 30%. Okay. What if he's a complete, like no activity, low to no activity? Should we give him single agent irinotecan? So is it absolutely necessary, right? So what would we do? We go back to our guidelines and we start picking anything else that we can pick, right? So what else could we pick maybe for him? For colon cancer, huh? There's no data with single agent oxaliplatin. So we could do single agent though what? 5-FU or single agent CAPE. We could maybe look, depending upon what his MSI status is, for immunotherapy. Okay. All right. If worse comes to worse, we could go to where? What are our two kind of later line drugs that we might be able to move up earlier? One starts with an R, has RAF in the middle of it, regorafenib, and then what's the other? The trifluridine to Pyrasil or Lonsurf, like we could think about that too. Okay. All right. So we talked about the FDA doesn't really have any kind of recommendations for this. Okay. All right. So let's let's move out of kind of oncology treatment drugs and let's talk about some other kind of drugs and other kind of drug metabolizing enzymes that may have deficiencies. All right. So you guys have heard about G6PD, right? Okay, what does G6PD do? So it breaks down glucose, right? Okay, when you're G6P deficient, what does that mean? What happens? You can't break these things down, and then what do? Okay, you put like these super kind of toxic things out in your blood, which causes hemolytic anemia, where your red blood cells get destroyed, especially when you're exposed to certain foods or certain chemicals, right? Because there's this stress because you're not able to break down that glucose, all right? What are the most common drugs involved with a G6P deficiency that we want to avoid? What? Okay. So a lot of our anti-malarial type drugs. Okay. What else? Aspirin, nitrofurantoin, NSAIDs. Okay. Dabrafenib. Where would we see dabrafenib? Melanoma. Okay. All right. We also see it with rasburicase. Where do we use rasburicase? All right. Tumor lysis syndrome. All right. So rasburicase is utilized in this tumor lysis syndrome to do what? What's his job? I told you we build all semester long, right? So tumor lysis syndrome, what things happen? Hypercalcemia, hypophosphatemia, hyperuricemia, and hyperkalemia. hyperkalemia. Okay, right? All right, so this has to do with the hyperuricemia, right? We get all this uric acid dumped out into the bloodstream. Your kidneys are trying to process it. Your kidneys like to process uric acid? Nope. Not fun for your kidneys, right? So rasburicase does what? It solubilizes, right, the urate oxidase into allotoin and hydrogen peroxide. Okay, then that way we can pee it out. Okay, so that's rasburicase is really important in our patients, especially our heme malignancy patients that develop tumor lysis syndrome. Okay, all right. So rasburicase itself is not an issue with G6P deficiency. So directly, those two don't interact. What happens is that when this process occurs and you get all this extra hydrogen peroxide, that's where G6P deficiency comes into play. Because if you're G6P deficient, you can't really metabolize all this hydrogen peroxide out, and then that puts stress on the cells, and that's what causes the hemolytic anemia to occur. Okay. If a patient has a G6P deficiency and we give them rasburicase, how are we going to know they have a G6P deficiency? How are they going to present? How will we know if we hadn't tested them? If you get hemolytic anemia, what's going to result in a patient? Okay, they might be tired. Huh? Say that again? Bleeding? Are they going to bleed? What is a hemolytic anemia? What does that mean? You're lysing your red blood cells. Okay, so when your red blood cells lyse, what happens? You're going to release iron. What's going to clear that blood out? Kidneys, but what's going to kind of break it all down? That's your garbage disposal of your body that my mom used to make me eat when I was a kid, and I was really furious when I went to pharmacy school. Liver, right? So you get liver. So if you get all the breakdown of this blood product in your liver, what lab value starts to go up? Not so much ALT and AST. Bilirubin, right? You get these byproducts of blood, right? And it increases your bilirubin. And how's the patient going to present? Jaundice, right? Right. So that's probably the main way they're going to present is kind of jaundice. You can have some other things requiring transfusions and things, but a lot of times they're going to present jaundice because they can't clear the bilirubin. Okay. All right. So there's CPIC guidelines for rasburicase in patients who are G6P deficient. Okay. So essentially, again, we don't always test our patients, but if you did test them, if they were deficient with G6P, right? So whether they were homozygous or heterozygous deficient, you would not recommend using rasburicase. If they're wild type or or heterozygous in a variant that has a more normal phenotype, you would give them rasburicase. Okay. All right. So just to know, we don't always just look at this for oncology drugs for treatment. We also look at it in a supportive care setting. All right, I'm not going to hammer CYP2D6 because I think Dr. Aquilante, very different. Dr. Aquilante, she probably would not like it. I called her Dr. Aguilar. Has probably talked about CYP2D6 and tamoxifen to you guys. Okay, so I'm not going to hammer that at all, just other than to bring it up. What's CYP2D6 big role with tamoxifen? Converts it to its active form, all right, endoxifen. So we really pay attention to not necessarily genomic mutations in this, but from my standpoint clinically, what do you think I pay most attention to? Drug-drug interactions, exactly. Okay, all right. So, so with this, we know with CYP2D6 and breast cancer, any kind of impact on CYP2D6 can affect overall survival. So people who are homozygous deficient, right, have lower survival than patients who are wild type. All right, so it's something that that we do kind of pay attention to. Testing's controversial. We still don't routinely test in patients. We really do try to avoid these drug-drug interactions. And if a patient has a poor response, then we're likely to go out and do some genomic testing when we know tamoxifen should be effective. All right, now the other thing that we can look at for CYP2D6 is that it plays a role in metabolizing our 5-HT3 antagonist that we use for nausea and vomiting. Okay, so ondansetron is the main 5-HT3 antagonist that we use in the United States that has primary metabolism through CYP2D6. Okay, so again, there's some CPIC guidelines here that look at what type of metabolizer you are, what type of activity score you would have, and then what that means from a genotype or a genotypic standpoint. Okay. So if we look at their dosing recommendations here, if you're an ultra rapid metabolizer, what is their recommendation here? You're gonna what are you gonna do if you're ultra rapid metabolizer of ondansetron? You're just gonna suck it right out, right? Put it in, suck it right out. Is it gonna help you with your nausea? If you're getting cisplatin, is that gonna be a good thing? No. Okay. So it recommends what? Trying to use something else, right? So it's not going to be super effective. How about if you're a normal metabolizer or an intermediate metabolizer? What does it say? Or even a poor metabolizer? Just normal dosing. Okay. So sometimes when we have patients who don't respond really well to their antiemetics, this is something that we may go and do some genomic testing to determine maybe or can we change up their antiemetics to give them something a little bit better. Yep. Mm-hmm. So if you give it IV form and you can avoid the liver, we will sometimes use it acutely for acute, like prior to chemo, but for that delayed piece, we won't use it in that patient population. But, I mean, we try to avoid it if we could. We don't, like I said, we don't normally test all of our patients, usually only if they're not responding to their antiemetics will we kind of respond. But yes, you could do that. All right, here's some other polymorphisms that we see in our patients related to drug metabolizing enzymes. We're not going to go into them, but in any detail, just because I want to get to the somatic stuff. But you can see that we also have things that play a role in some of our antimetabolites as well as our platinum agents. Okay. All right, so somatic mutations. We'll kind of run through these because we've seen these before. BCR-ABL is kind of our classic drug mutation kind of story, right? This was the first mutation where we were able to identify a drug to treat that mutation. So it became an actionable mutation. And with that, we were able to dramatically improve overall survival in these patients who had CML, or chronic myeloid leukemia. So BCR-ABL is a protein tyrosine kinase. It's a result of a translocation in chromosome 9 and 22, which is also known as the Philadelphia chromosome when you get this translocation. And it's associated with the development of CML. So you see here, you see ABL, right, on chromosome 9 and BCR on chromosome 2. They break off and then they develop this BCR-ABL. When that is made, it becomes constitutively active. And in that, then it starts making these proteins, and this protein then turns into, or then causes the development of leukemia in these patients. Okay. So what we see, we have a whole bunch of BCR-ABL drugs, and where these BCR-ABL inhibitors play a part is, right, this is the BCR-ABL tyrosine kinase, okay, and this is the substrate. Right, so this is where we're kind of activating this pathway. And normally ATP will come in and bind that pocket and cause the activation and lead to these downstream pathways that will develop CML. Where our BCR-ABL inhibitors come into play is they come in and they bind that pocket, preventing ATP from causing phosphorylation and the activation of those downstream pathways. So imatinib was our first BCR-ABL drug. And then since that came out, it was kind of like our BRAF inhibitors. When it first came out, we gave it to everybody. It worked great. But then what did we see? resistance, right? So then we started developing second generation BCR-ABLs and third generation BCR-ABL inhibitors. So now we have imatinib, dasatinib, nilotinib, bosutinib, and ponatinib. Okay, say those all 5 times. It's really fun. Okay. All right. So because of these mutations in these kinase domains, then we saw decreased survival. So we developed these newer drugs. So this is just kind of a map looking at the different types of mutations where they occur, and the different type of mutation, and then looking at the sensitivities of these drugs to those mutations. This really helps us kind of, where else have we seen this? Lung cancer, right? And we'll talk about EGFR, right? So we've seen this kind of map. What drug has the best activity? Is there any one drug that has any better activity than the other? Right, so maybe bosutinib has the best activity. Is there any mutations that nothing really responds to? What's this one right here? It goes all the way across. Can you guys read that with your tiny print? Yeah, so the T315I mutation, so that's a point mutation, is a mutation that's resistant to all of our BCR-ABL inhibitors except for ponatinib. Ponatinib's the only one that has any kind of sensitivity to it at all. Okay, so this is important. So in these CML patients, if they start to lose their response, their initial a BCR-ABL inhibitor, we're going to do this kind of testing. We're going to determine what mutation they have, and then we're going to adjust therapy based on that mutation and these sensitivities. Okay. All right. The other thing you have to worry about with all these BCR-ABL inhibitors is they have tons of drug interactions, so we have to play around with that too. But that's not for this class. We're only going to worry about mutations. All right, so ponatinib is our last generation BCR-ABL drug. It's resistant. It's sensitive to pretty much everything, and it's the only one that has activity against this T315I mutation. Okay. Interesting thing with ponatinib is you can see here where if you have this mutation, what your response rates are if you get ponatinib versus a drug that's resistant to it. So you can see huge increases in survival. When it first came out in the market, it had lots and lots and lots of toxicity with it. It had all these cardiovascular events, narrowing of the blood vessels to the heart, all sorts of things. So the FDA eventually suspended the drug from use till they figured out what was going on, how this was happening, how they could educate people how to use it more appropriately. And then they slapped a REMS program on it and then put it back out in the market. That was about 2015 or so. And just this year, they pulled the REMS program off because people are now really utilizing it only in these T315I mutations, where before they were just kind of using it for just using it up front. So cool drug, works in this kind of unique mutation, but we had to learn how to use it appropriately before it was allowed back in the marketplace. Okay. All right, EGFR, I'll kind of walk through this quickly. It was one of our first in lung cancer, the mutations that we identified. So it was actually identified back in the 80s, but the use of our TKIs didn't really come into play until early 2000s. When it first came out, we, of course, like we do with everything, we say, oh, let's just add our TKI to chemo, and then let's, treat them, right? Because TKI and chemo, more drugs better, kill cancer, yay, that kind of thing. So what we saw, though, when we added the TKIs to the chemo, what happened to patients? Did they have a better or worse outcome? They had a worse outcome, right? All right, and so this is where we came into play. Like if you give chemo to a patient who has an EGFR mutation, they actually do worse than those who don't. Okay. But what they did see in this study is that there was a small group of patients who did respond. And so then we had to go start fishing out, like, why did they respond and everybody else not respond, right? So then that's where we really started figuring out the role of EGFR and these mutations in lung cancer. So these early evaluations looked at the expression of EGFR, and they looked at the amplification of EGFR, and essentially showed that there were activating mutations that were occurring, right? So kind of activating downstream, so constitutively activating the pathways to develop our cancer, right? And then treating those would cause responses. Okay, so just put this up here to remind you, right, for these receptors to cause these downstream pathways to occur, they have to dimerize and then intracellularly phosphorylate. All right, and this is where we start to see a lot of the mutations occur, kind of in this intracellular tyrosine kinase domain, because then the drug can't come in here, right, and can't bind and can't and do what it's supposed to do. Okay. All right. So EGFR mutations, we know in lung cancer, these are activating mutations. Okay, so these are not loss of function mutations, these are gain of function mutations, right? So a lot of the drug metabolizing things we talked about were loss of function. So we know they most likely occur in either exon 21, where we have that point mutation, or when we have deletions in exon 19. Those are about 90% of the EGFR mutations that we see occur. All right, but importantly to remember, not all mutations in EGFR are constitutive, okay, and not all activating mutations confer sensitivity to our TKIs. Okay, so if you've got activating mutations in 21, exon 21 and exon 19, that means those EGFR drugs are sensitive. Okay, if they occur in exon 20, it usually doesn't infer sensitivity. And what do you see here? What is the primary mutation in exon 20? T790M. And what do we know about T790M? Okay, so it's resistant, right? Erlotinib's resistant to it, afatinib's resistant to it, gefitinib's resistant to it, right? So that mutation doesn't confer sensitivity to those drugs, right? So that's where we had to develop osimertinib to work against that T790 mutation. All right, so this is just an example of like where these things occur on the exon, okay, of this tyrosine kinase. All right, so resistance usually is T790M, but there's a couple of different other resistance patterns or mutations that can occur. So definitely things in the exon 20 will confer resistance. And we do see a point mutation in exon 19 that does confer resistance. Okay. So we know T790 is the most common, right? We use osimertinib in this setting. And this is Dr. Pacheco presented this. So we give osimertinib, usually second line, when they develop that T790 mutation. And what eventually will happen? All right, they essentially get a new mutation, and what happens here? What happens to T790? It goes away, all right? So the cancer is constantly adapting to the pressures that we're putting on it, all right? So here, this is looking at the number of patients, it's looking at survival. If they have T790 loss, they don't live for very long, right? Because now we don't have, we haven't come up with the next big drug. Okay. All right. So again, these tumors can be very smart and somatic mutation wise, and can adapt to the stressors that we're putting on it. So we're constantly going to have to be looking at these mutations and using these mutations to drive new drug development. Okay. All right. So mutations outside the EGFR kinase domain. Okay, so this is not not in that kinase domain. These are outside the kinase domain. We know that if you have this intron 1 cysteine adenine kind of repeat polymorphism, that actually confers improved survival to cetuximab. So that's kind of a predictive for cetuximab. And then we know with KRAS and BRAF, right, if we have KRAS that's constitutively activated outside the EGFR domain, what happens? right? Our EGFR inhibitors don't work, all right? Okay, so we know that happens, and we know that eventually, once we learn that it changed the labeling of how we use our drugs, okay? So this is just KRAS. I won't walk through that, but you guys know all of that stuff on that slide. All right, this is where we show that patients who are KRAS wild type versus KRAS mutant, if we give them cetuximab, if they're mutant, they don't respond. If they're wild type, they do. All right, and then we can look at other drugs or other mutations in this kind of MAP kinase pathway, right? So we look at EGFR, we look at KRAS, we talked about BRAF, right? If BRAF is activated, what does that tell us about some of our EGFR inhibitors in colon cancer? They may not work as well either, right? Because it's downstream of KRAS. And then we talked about PIK3CA. Dr. Davis talked about that. Those patients who have PIK3CA, what do they benefit from? Aspirin. Okay. All right. There's PTEN mutations. There's AKT mutations. So there's a whole bunch of other mutations that may predict response in these patients or predict prognosis that we're looking at how we can utilize them in colon cancer. All right, so another kind of in that kind of EGFR domain is HER2. HER2 is used in what cancer? Breast cancer, right? We use IHC and FISH testing to kind of determine HER2 status, right? We know that it's a poor prognostic factor, but we have a drug to treat it, so that's helpful. Our drug of choice is trastuzumab, right? But we do see primary resistance. So patients who get trastuzumab can likely develop resistance within the first year of treatment. That resistance can be either primary versus that should be acquired, not required. I don't know what I was thinking. All right, so primary resistance. So what's primary resistance? They're just resistant to at the get-go, right? They were never going to respond. So that could be a mutation right off the bat in HER2 that doesn't allow them to ever respond. So acquired, not required, acquired is, yeah, something that kind of develops over time. So a lot of our mutations are acquired mutations in these kind of targeted areas, because the more we expose the tumor to the drug, the more they develop a way to work around it. So some of these acquired mutations may be associated with the development of this MUC4. This is a kind of a mucinous receptor that develops that can cause resistance. We can see altered downstream signaling, so maybe you get something downstream constitutively activated. And then also we can see kind of a truncated expression of HER2. So you got HER2 up there, but it's not real HER2, so trastuzumab can't bind to it. So we kind of see this resistance developed. So to overcome this resistance, we can add pertuzumab. What's the advantage of pertuzumab? What does it do? It binds to a different epitope, right? So a different domain. So we might be able to work around some of this resistance that's developed. Or we can use lapatinib. Lapatinib is, it's an oral TKI, right? So work intracellularly, not in the extracellular domain. All right, ALK inhibitors. Right, we know ALK's translocation of EML4 and ALK. So we get like BCR-ABL, we get this constitutively active protein that causes lung cancer. We know that if you give chemo to these patients versus ALK inhibitors, that they do worse on chemo, so we really need to use targeted therapy. We can see resistance that develops to these ALK inhibitors, just like we see with the EGFR inhibitors and the BCR-ABL inhibitors. So we get mutations, point mutations in ALK. We can get activation of these kind of second messenger pathways. We can overexpress ALK, so we have more receptors than drug, or just the fact that if it can't get into the brain, then we have resistance kind of develop there. All right, so similar to what we saw with our EGFR inhibitors and our BCR-ABL inhibitors, we kind of map out these mutations that can occur and what's sensitive and what's not. The biggest mutation here that we see that we have sensitivity to is pretty much everything is sensitive, right, to lorlatinib. lorlatinib, which is not FDA approved yet. But you can see some of our others, we have mutations occur, or mutations that cause resistance in patients. Okay. All right, so where does this all fall out in oncology studies? All right, so almost all of our studies now will have some kind of tumor profiling. There's hardly any studies that we do anymore that don't incorporate this as part of its study design. All right, you can either come about it either prospectively in kind of a GWAS aspect, or you can do it hypothetically as a retrospective. Right, so KRAS came about from a retrospective review of a bunch of patients, and then the EGFRs came out from a kind of a prospective review. You can use it in the preclinical setting and in the clinical setting. Optimal studies, you have to have biologic material, and sometimes that can be really hard. Sometimes patients' tumors aren't accessible, and so to get tumor tissue to be able to do this genomic profiling can be very difficult. All right, so that's a problem. So can we use surrogate tissue? Can we use normal tissue? Maybe, maybe not. Or can we use circulating DNA? What are different ways that we can access the cancer DNA without maybe getting to a tumor that we can't access? You have to basically appropriately select your patients, and you need an adequate sample size to determine, right, if these genomic studies are going to be appropriate. So, like I said, in oncology, almost all of the studies we're doing now have some kind of genomic profiling because we're seeing how it can optimize drug therapy and patient outcomes. These strategies here aid in the development. These pharmacogenomic strategies aid in the development of biomarkers and these companion diagnostics that are helping us change the way we treat patients. And there's lots of benefits here, right? So improve response rates for patients, right? You have lung cancer patients who had normally lived maybe a year, now live 7 years, right? And improve survival. We can sometimes do trials with a smaller number of people over a shorter amount of time. And then that is always favorable because it decreases drug development costs and maybe can decrease overall drug costs. Maybe, maybe not. All right. And then drawbacks here, not all patients have mutations. Trust me, I prayed every day my mom would have at least one mutation for her lung cancer, and she didn't have any. So not everybody has a mutation. Not everybody has not all mutations are actionable. So not all mutations have drugs that will hit them, right? And then not all patients with actionable mutations respond. And so we still need to do further research on why that happens. Okay. Questions? Genomics in a nutshell. Okay. All right. So a lot of it's review of what we talked about before, but maybe just some deeper application of it. If you guys have any questions, let me know. Happy Tuesday.